This program is brought to you by Emory University.
I'm Joe. See, I'm one of the, I think everyone here probably, I'm looking at the participant list. I think almost everyone here knows me. Um, I was a fellow here for a long time, and I stayed on. I did an extra year of cardiac imaging with the structural team. And so my role currently is a combination of general cardiology as well as providing imaging support for the structural team. Ozma invited me to give you guys a talk about aortic stenosis and specifically, echocardiographic evaluation of aortic stenosis. I kind of tailored this talk more towards first year fellows. I think it's still early on in the year to kind of go through some of the nitty gritty details of how to properly echo the aortic valve. But I think, some of the upper level fellows can probably hopefully, pick up a couple of things related to this as well. So we will go ahead and get started here. No disclosures. If you guys want a good reference for any of the material from this talk, a lot of it was from this paper in JACE in 2017 or 2018, which I thought was a really, really good review. So talk today is basically divided into three different sections. We'll kind of quickly go through aortic valve anatomy, and then we'll spend the bulk of the talk actually going through some images just to see how you're actually supposed to measure aortic valve stenosis. And then at the end, I'll kind of briefly cover some issues with some of the low flow states and how that impacts echo evaluation of AS. So valve anatomy. This cartoon here on the left, I put it on here mainly to kind of show you that on an axial view, cross section of the heart, the aortic valve is kind of sitting right in the middle, surrounded by the three other valves. For most patients, there are three leaflets, the left, right, and the non, which makes sense because the left comes off the left cusp. The left coronary artery comes off the left cusp, the right RCA comes off the right cusp. There are a lot of important structures in here, including here you have the mitral valve, and this is what we call the aortomitral curtain, which is this fibrous tissue that connects the anterior leaflet of the mitral valve with the aortic valve. If you look at the aortic valve in more of a sagittal view, you can kind of see how the leaflets are folded into the sinuses of Valsalva. At the nadir of the leaflets, this is what we would define as the aortic valve annulus. And then below the annulus is the left ventricular outflow tract. The sinuses of Valsalva meet here at the sinotubular junction. And then above the sinotubular junction is your ascending aorta. And here you can also see this fibrous continuity between the aortic valve and the mitral valve. The one thing that's not shown in here is that you also have your your AV node that's kind of sitting back here as well. Hold on, something happened here. Okay, here we go. So this is, for those of you that have done TEs, this is kind of your standard long axis view of the aortic valve. And I think this is just kind of like a real life demonstration of what that cartoon was trying to show you, where you have your LVOT, your aortic valve annulus, your sinuses of Valsalva, then your STJ, and then your ascending aorta. Here on the left is a transthoracic short axis view of the aortic valve, and then the picture on the right is a transesophageal short axis view of the aortic valve. And what I wanted to highlight here is just the three aortic valve cusps, the left, the right, and the non. And initially when I was a fellow, I had a hard time. I was just trying to memorize what each of these leaflets were. But really, the easiest way to do it so that you're not confused going back and forth between transthoracic and transesophageal is just to see what the structures are adjacent to the leaflets. So, your right coronary cusp is adjacent to your RVOT. It doesn't matter if this is on the transthoracic or the transesophageal, because your RVOT and the TE is down here. Your non is usually adjacent to the, right here, your interatrial septum, here on the transthoracic, and here on the transesophageal. And then the third one is just the left. So one thing to kind of keep in mind is that, aortic stenosis, we typically think of as valvular, but it can also be either above the aortic valve, or the stenosis could either be above the aortic valve or below the aortic valve. The next two slides were borrowed from Robbie's talk. He'll kind of go over some of the more clinical implications of AS with you guys. It's a good talk. I just stole two slides, one about supravalvular stenosis. Classically, it's been associated with Williams syndrome, which is obviously no relationship to our Dr. Williams. But really what this is just a narrowing of the STJ above the aortic valve. And then you can also have subvalvular stenosis. And this subvalvular stenosis could be either fixed or dynamic. Typically, when we think about it being fixed, you're talking about an overgrowth of mitral valve tissue that forms a membrane in the LVOT, or there can be also like a tubular narrowing of the LVOT. And usually when you see that, the thing you would think about would be Schoen's complex. And then of course you have hypertrophic cardiomyopathy, where you actually have a dynamic subvalvular stenosis due to LVOT obstruction from a thick septum and SAM. And I think the thing that will kind of tip you off is not only the contour of the jet that you're getting, but also the aortic valve leaflets themselves actually look like they're moving. But again, I'll kind of let Dr. Williams go through that in a little bit more detail with you guys. I want to focus more on valvular aortic stenosis for the sake of this talk. And for the most part, it's usually either because it's calcific, rheumatic, or there's some sort of congenital abnormality. The patient's age can usually tip you off to what it is. Younger patients less than the age of 70, if they have AS, it's usually because they have a bicuspid aortic valve. If they're older, it's usually because they have a calcific degenerative aortic valve. So briefly with bicuspid aortic valves, it's about 1% of the general population. Some of the clues that you can look for on echo would be that, especially in the parasternal long axis view, you can sometimes see an eccentric closure line of the leaflets. And then in systole, sometimes you can see the leaflets dome and then prolapse in diastole. And that's the thing that I wanted to highlight here in this video. In the parasternal short axis view is really kind of where you confirm that it's bicuspid. Of course, this depends on actually being able to see the aortic valve leaflets in the parasternal short axis view, which is not always easy. But if you can see the leaflets, you'll kind of notice, it's subtle, you have to kind of look at a few of these, but that it's kind of this ellipsoid opening, and it's not that the Mercedes-Benz kind of symbol that you see. In this particular case, I think this one might actually be, I can't tell if there's a raphe here, but this one might even be a type 0. But anyway, there are 3 types of bicuspid valves based on the Sievers classification. Basically, there's type 0, 1, and 2. 0 means that there are no raphe. It's a pure bicuspid aortic valve. Type 1, there's usually 1 raphe, and that is the most common type. And it's usually between the left and the right is where this raphe is. And that basically just means that there's this fusion of the commissure between the 2 cusps. And you can see that this happens in the vast majority of cases, is between the right and the left. A couple of important things to kind of note for bicuspids is that you really have to see the valve in systole, because the thing is in diastole, because if it's a type 1, they will still have this raphe there, And that can fool you into thinking that there are three discrete leaflets that open, right? But only in systole do you see that this one right here does not open. And of course, if you do confirm a bicuspid aortic valve, make sure that you measure the size of the aorta, because 50% of the time they can have dilation of the aortic root and ascending aorta. And then the other thing to keep in mind is that 6% of the time they can have a coarct. So you'll have to take a good look at the suprasternal notch views, get some pulse wave Dopplers and things like that. Now, this is, I think, a board question, and that's, patients who have a coarct, 50% of them will have a bicuspid valve, but patients who have a bicuspid valve, only 6% of the time will they have a coarct. You can also have rheumatic aortic stenosis. I've never seen this happen without also having mitral stenosis, rheumatic mitral stenosis. But basically, these patients don't have leaflets that are that calcified. It's mostly just a commissural effusion like you would see with rheumatic MS. So that's kind of a brief overview of the anatomy. Let's kind of get into the bulk of the talk about actually how to measure aortic stenosis severity. This is a table of how to grade mild, moderate, and severe. I think, probably a third year or fourth year medical student should already have this table memorized. So we're not gonna go through, what the definition of severe is, but I am gonna kind of walk you guys through how to obtain each of these measurements. So the first one that we'll talk about is the peak velocity through the aortic valve. And for this, you would be using your continuous wave Doppler. I have a couple of kind of physics concepts that are scattered throughout this talk that I think are important to understand. The first thing is with echo, the way that you are actually measuring velocity is through the Doppler principle. And what you're actually measuring is you're measuring what's called a Doppler shift. And that is basically just a difference between the frequency of the sound wave going from the transducer and hitting the blood cells, and then the frequency that it then receives. The reason this is important, you have to memorize this when you take your echo boards, this equation, but for the purposes of this talk, what I want you guys to focus on is this thing here, which is cosine theta. Theta is the angle between the ultrasound beam from the transducer and the flow of the red blood cells. The bigger this angle, the more inaccurate your Doppler shift is going to be. So a little bit of math here, cosine of 0 degrees. So if you were parallel to the flow without any angle, that is 1. And so whatever your velocity you're measuring is probably the true velocity. Now, if you are at cosine 90, so now you're completely perpendicular to the flow of blood, cosine of 90 is 0. So you're not going to be able to measure any sort of velocity with that angle. And you can see here that if your angle is 60 degrees off from the direction of the blood flow, your velocity is probably going to be cut in half of what the true velocity actually is. And so really, if you can try to kind of keep that angle 20 degrees or less, you're probably going to be pretty accurate. Because if you're at 20 degrees, you're probably only going to be off by about 6% from what the true velocity is. So that's the first concept to keep in mind that I think is very important. The second thing is, classically, we measure our aortic valve velocities from our apical views. But in fact, 60% of the time, your right parasternal view actually will give you the highest velocities. And it really just depends on what the orientation of your LVOT is with your aorta. Someone whose heart is tilted this way, as you can imagine, the right parasternal view, you're going to get that beautiful parallel look down through the aortic valve. And then suprasternal views are also helpful and can also give you some higher gradients. So don't just limit yourself to your apical 5 chamber or your apical 3 chamber. The other thing is you can also consider the PDOF probe to get your continuous wave measurements. And then I put this here as well. By the book, technically we're supposed to do a 3B average of our velocities and gradients if they're in sinus rhythm. If they're in AFib, you're supposed to average beats. You know, in practice, I think that takes a lot of time, and I don't know if anyone truly does that, but that is one thing that by the guidelines you're supposed to do. Another thing to keep in mind is post-PVC beats. Do not measure the post-PVC beats because those are going to be artificially high. So that was velocity. So what about your actual gradient now? So the concept here is that we have this relationship, courtesy of Bernoulli, of the relationship between velocity and pressure. And that equation is 4 times your peak velocity squared is your peak gradient. Now, if you have an elevated LVOT LVOT velocity at baseline of greater than 1.5 meters per second, you're technically supposed to use a slight modification of that Bernoulli equation, and that becomes V2 squared, which is your aortic valve gradient, aortic valve velocity squared, minus your LVOT velocity squared times 4. The other thing to keep in mind when you are tracing, sorry, they're texting me from on service at the CCU right now. Okay. Another thing to kind of keep in mind is the actual contour of the jet. And the reason that this is important is because the patient also has mitral regurgitation, or if they have hypertrophic cardiomyopathy with some sort of, LVOT, subvalvular LVOT, subvalvular stenosis, you can get fooled into measuring velocities and subsequently gradients that are not actually coming from the aortic valve. So one way to kind of differentiate between aortic stenosis and mitral regurgitation is just the duration of the flow. So with AS, you shouldn't see any flow until the aortic valve actually opens, right? And that flow should go away once you see the aortic valve close. The mitral valve closes before the aortic valve. This is your isovolumic contraction time. And so with MR, you will see that flow happen earlier in systole, right at the R wave. And then with hypertrophic cardiomyopathy or mid-cavitary obstruction, LV2 obstruction, typically what you'll see is a much later peaking velocity. So don't be fooled by MR and other forms of subvalvular stenosis. Here's another important concept, and this is correlating our echo measurements of gradients and velocity with our cath measurements. So bring your attention first to this picture on the left. The timing of the peak LV pressure and the peak aortic pressure is different. They don't happen at the same time. The peak aortic pressure happens later. And so in the cath lab, when you're measuring your peak to peak gradient, that's probably not capturing the biggest difference between the gradients. And so echo measures this maximum instantaneous gradient between the LV and the aorta, and that's why typically the peak gradient that you get by echo is higher. However, the mean gradients between echo and cath should correlate. Here's another concept for you guys to be aware of, and that is the concept of pressure recovery. And so, when you're measuring pressures by cath, you typically will have, if you're using 2 transducers, you'll have one that kind of sits here in the aorta, and you'll have one that sits here in the LV. But if you actually look and see how the pressure changes going with the blood flow through the aortic valve, your velocities are highest here in your vena contracta, where this flow is the most narrow. But what's interesting is at this point, there's a pressure drop. And that's due to changes in your kinetic energy and heat and things like that. And so when the velocity is high right here, you also have the lowest pressure. And that's what you can measure by echo with your CW Doppler. And that's why you're measuring the maximal difference in pressure. By the time you get to where your actual catheter is in the cath lab and sitting in the aorta, some of that pressure has already recovered. And so that also diminishes that gradient between your LV and your aorta. And so this happens all the time is we do a TAVR on these patients, and in the cath lab, they're getting a gradient of 8 after the TAVR is put in, and then you do an echo on them the very next day, and we get a gradient of 12. And this concept partly explains that discrepancy. So now we've talked about aortic valve, we've talked about velocities, we've talked about gradients. Let's move on to the aortic valve area. So based on the principle of the continuity equation, which is conservation of mass, basically what you're saying is that what flows in must flow out. So, you know, the area of your LVOT and the velocity of that flow should equal the area of your aortic valve and the velocity of that flow. And if you were to just rearrange that equation, you can calculate your aortic valve area, which is then equivalent to your LVOT area times your LVOT velocity divided by your aortic valve velocity. So let's talk about, so you basically need those three numbers in order to calculate an aortic valve area. So the thing that's probably the hardest to do, and the thing that leads to the biggest discrepancy in aortic valve area, is incorrect measurements of your LVOT area. And the reason is that area is pi r squared. So if your R, or your diameter divided by 2, is off, you're squaring that number, and you're exponentially, increasing the error of measurement. The way you're supposed to do your LVOT diameter measurement is you zoom in on the aortic valve in the parasternal long axis view, and in mid-systole, which is not only when the annulus is the biggest, but also when it's the most circular, you measure inner edge to inner edge parallel to your annular plane. Now, it's important to make sure that you also have an idea of how big the person is and what their body surface area is. The LVOT diameter doesn't always correlate with body size, but if you're getting a large LVOT diameter, which is typically what we think of greater than 2.5, and the patient is tiny, you're probably measuring it wrong. And vice versa. If the patient is big and you're getting an LVOT diameter that is small, which is typically what we think of, in the high ones, anything below 2, really, and you're getting an LVOT diameter of 1.5, you're probably measuring that wrong as well. The important thing to keep in mind is that our measurements of the LVOT by echo is actually inherently flawed. And that's because once we started looking at these CTs, you actually realize that the LVOT is an oval. It is not a circle. And so if you're not measuring your LVOT diameter across the longest axis of this oval, you are going to be underestimating what the true LVOT diameter is. Unfortunately, by echo, there's nothing you can do about it, but just keep in mind that usually we are underestimating the LVOT diameter. And so, people have kind of questioned, all right, well, should you measure the LVOT right at the aortic valve annulus? Should you measure it 5 millimeters back from the aortic valve annulus, maybe even a full centimeter back from the aortic valve annulus? And the reason is that theoretically, you should be measuring it where you are also measuring your LVOT velocities. However, if you look at some of the more recent talks from Mayo or the ASE, excuse me, people are actually moving towards measuring this diameter right at the aortic valve annulus. And that's because we have the best reproducibility at that spot, particularly in patients who have thick LVs or even patients who have sigmoid septums, which is shown here. This is probably a gross underestimation if you're measuring it 5 millimeters, to the left of the aortic valve annulus. And so that's why people are now moving towards just measuring the LVOT diameter right at the aortic valve annulus. The aortic valve annulus can be tricky because it can also be calcified. The LVOT can be calcified right here. You're supposed to measure through that calcium. So all this talk about LVOT velocities and VTI. So another physics principle here is that flow is typically equal to area times velocity. However, this is if flow through an orifice is constant. Obviously, in the heart, it's pulsatile. And so there's this concept called VTI, or velocity time integral, where you're essentially accounting for the differences in velocity over time. Now, our typical views are still the apical 5-chamber, the apical 3-chamber, and then of course, we talked about some of the other alternative imaging planes. And what you want to do is you want to place now your pulsed wave Doppler and place that sample volume in the LVOT, just apical to flow acceleration. What does that mean? So put color on the valve, and when you see this flow acceleration, this yellow to this blue, this kind of border right here, put the pulse wave Doppler just apical to it. Don't put it in it. You're too close to the valve then. If you put that pulse wave Doppler right here, what you're going to get is you're going to get a big LVOT VTI tracing, and you're also going to see this aortic valve closure line. From there, you want to bring that pulse wave, that sample volume, more apical outside of this flow acceleration until that aortic valve closure line disappears. You should not be seeing an aortic valve closing click. The other thing is you want to avoid spectral broadening. What that basically means, and what you want to do is you want to see laminar flow, and you want to trace this modal velocity. What that basically means is, that this is laminar flow, and that the blood cells are all traveling at about the same velocity. When it's kind of this blurriness in the middle, we call that spectral broadening. And that means there's a lot of turbulence. Sometimes you can't do anything about it, but you can, if you decrease your gain a little bit, you'll get rid of some of these, what we call whiskers. It's not the technical term, but these whiskers are basically, red blood cells that are traveling at higher velocities than other red blood cells. What you want to do is you want to trace what most of the red blood cells are doing. So we talked about LVOT area, LVOT VTI, and that third piece of the puzzle is your aortic valve VTI. Same concept, but this time you put CW through that aortic valve. And again, we talked about, don't forget about your transducer angles, and don't forget about your transducer location. This is another thing that can lead to some erroneous measurements, and that's if you see this double density, that means you're probably not perfectly through your vena contracta, through that highest jet in the middle. You want to see something like this. You don't want to see this double density. So you may have to move that CW line a little bit to the left, a little bit to the right, until that double density disappears. Fourth concept. So we talked about velocity, gradient, area, something else called dimensionless index. And that actually is also derived from your continuity equation. Basically, you just divide the two velocities of the LVOT and the aortic valve. And a dimensionless index of less than 0.25 is severe. And what's important about this is this doesn't depend on your LVOT area, right? You're cutting out this factor. What else can you do? Well, 2D assessment of the aortic valve is something that the more I read echoes now, the more I appreciate. If the gradients don't correlate with what the valve is actually doing, you're probably measuring the gradients wrong. If the valve looks like it's opening and your gradients are really, really high, you're measuring something wrong. And vice versa, if the valve is not opening at all and you're getting really slow gradients of velocity, there might be, the patient might have low flow, and we'll get to that in the last part of this talk. You can also planimeter the aortic valve area, which is supposed to correlate with cath-derived areas. Now, on TE, it's a little bit easier than on TTE. However, with the new Philips machines, as long as you have the X-plane technology, you can still do it on transthoracic echo. And the reason I say this is because you want to be measuring at the leaflet tips. So here on this picture on the left, it looks like the aortic valve is nice, wide open. It's not normal, but it looks like it's open, right? But what the problem is you don't know if you are at the base of the leaflets where it's going to be bigger, the aortic valve area is going to be bigger, or if you're truly at the tip of the aortic valve leaflet. So what you want to do is you want to see a long axis view of the aortic valve, and then you put that X-plane right through the tips of the aortic valve, and where you're supposed to trace and get your planimeter aortic valve area. So don't just take one parasternal short axis look or a short axis look on TEE. You need to find a long axis view of the aortic valve and X-plane through the tips before you planimeter the valve area. Some other metrics, don't forget about concurrent AI. Make sure you look at the LV for both hypertrophy as well as systolic diastolic function. A lot of patients with long-standing AS will have pulmonary hypertension. Measure some, get estimates of your RVSP and your RV function, and also your mitral valve, whether there's mitral valve pathology. If you have calcified aortic valve, it's possible that you could also have calcified mitral valve annulus. Maybe the patient also has some concurrent MS, maybe MR. And then the last thing is strain can be helpful as well. There have been some studies that have looked at patients who have low global longitudinal strain, even if they're asymptomatic. This is kind of what they define as subclinical LV dysfunction. And maybe these patients we need to operate on sooner as well. You can see that patients who have strain of less than -12 do worse. So, when you're grading aortic valve stenosis, it's not just this table. All of this table is important, but hopefully by walking through how to get correct measurements of velocity, gradient, and area, hopefully that'll help you guys out. But don't forget about some of the other things, especially the 2D view of the aortic valve, planimetering the aortic valve, some of the other strain of the LV, and things like that. I think we're getting to the last part of the talk now. So I just put this quick slide in here. If you have severe AS, you should probably be imaging these people every 6 to 12 months. Even sooner if you think that you're not sure if they're having symptoms or their LV is starting to dilate or something like that. If it's solidly moderate, you can probably get away with every 1 or 2 years, and then if it's mild, every 3 to 5 years. But certainly, if there's any kind of clinical change, I wouldn't just wait on those parameters. I put this on here in terms of stages of AS because this also kind of guides who you send for either TAVR or surgical aortic valve replacement. Basically, anyone who is in stage C2 and lower should probably get their aortic valve replaced. And so C2 is basically severe asymptomatic AS, but the LV is starting to give out. And then stage D is anyone who's symptomatic. And that includes these two classes of low flow patients. And that's the last part of this talk. So low flow states, again, I'm putting this equation back in here. Flow is your area times your velocity. So it would make sense that if your flow is low, that your velocity is going to be low, right? So in your classic low flow, low gradient AS patient, they have some terrible cardiomyopathy. Their EF is 20%, and the valve by 2D looks like it's calcified with poor leaflet excursion, but you're getting gradients of 20 millimeters of mercury. Paradoxical low flow, low gradient AS, what that is your EF is actually normal, but your stroke volume is low. And I have a slide for both of these concepts. I'm not going to really cover normal flow, low gradient AS or moderate AS for the purpose of this talk. So what's classic low flow, low gradient AS? So again, like I said, patients who have low EF, however, their Vmax and their mean gradient, sorry, let me take a step back. They have low EF, and their calculated aortic valve area suggests that that person has severe AS. However, you're getting Vmaxes and mean gradients that don't correlate. And like I said, this is based on the concept that if your flow going through the valve is low, you're not going to be able to produce high gradients. So what you would do to figure this out is you give them a little bit of dobutamine. So low dose dobutamine, which is from 5 to 20 mics. And then you see if you can, by augmenting their stroke volume, if you can increase their Vmax over 4 or their mean gradient over 40. And if you can, that person has truly severe AS. That's classic low flow, low gradient AS. They need an aortic valve. If you're still not sure, but you were able to kind of bump up their stroke volume by at least 15%, you can actually use this separate equation, which I won't go through in detail today, but this projected aortic valve equation, which basically means they basically say, all right, what is your projected aortic valve area if you had normal flow? And the way they define flow here is your stroke volume divided by your LV ejection times. This concept is one that is still relatively new, but growing in popularity, because right now, the way that most people kind of think about flow is, the first thing is, what is your LVEF? Then it's, what is your stroke volume? But this concept integrates stroke volume with actually how long the LV is ejecting blood, this flow rate. And that may be a more accurate way of measuring flow. Another thing you can do in addition to a DSE is a cardiac CT. And there have been a number of papers that have looked at calcium score of the aortic valve leaflets. If it's greater than 1,200 in a woman or greater than 2,000 in a man, that person probably has severe AS. And then lastly, this concept of paradoxical low flow, low gradient AS. So again, what is this? So now you have a normal EF, but your aortic valve area still suggests that it's severe, but your velocities and your gradients don't correlate. Why is that? How is that possible if someone has a normal EF but have low flow? Well, that's because EF does not equal stroke volume, right? EF is your stroke volume divided by your end diastolic volume. So in patients who have tiny LVs with LVH and terrible diastolic filling, they're going to have a normal or even high LVEF. But if you measure their stroke volume, the stroke volume will be small. And you see this in, like I said, in these little old ladies with tiny LVs and restrictive filling. You also see in patients with mitral stenosis. You can also see patients with AFib, MR, which can decrease your preload, or patients with really bad hypertension, which can give you this high afterload state. How do you work this up? Probably a cardiac CT. The short answer is no one really knows. The short answer is cardiac CT. And again, just looking at that aortic valve calcium score. Would you do a low dose DSE on these patients as well? The data are kind of mixed on that. I think if you think about it, it doesn't really make sense to do that because yes, you might be able to increase your stroke volume a little bit, but these patients have tiny LVs. The minute you give them dobutamine, you're gonna make them so hypercontractile that they're gonna get symptomatic on you, and you're not gonna get good results. So I probably wouldn't send these type of patients for a DSE. So putting that all together, if you have discordant grading between your aortic valve area and the velocities or pressures, look at the EF. If the EF is low, they're probably going to be in this classic low flow, low gradient category. If their EF is normal, look at their stroke volume. If their stroke volume is low, then they're in this paradoxical low flow, low gradient category. If their stroke volume is normal, this is that third kind of category that no one really knows what's going on with. So I'm not going to talk about it during this talk.
The preceding program is copyrighted by Emory University.